What's up, guys? Dr. Uz here from the Dr. Uz Talks YouTube channel. Once again, thanks to everybody who's liking, subscribing, tuning in to the videos. And today it's going to be a little bit of a longer video, and it's going to be in two different parts because we're going to be talking about NHS dentistry. And there's a lot of kind of videos about this subject on YouTube, but most of them they don't really get to the point of why you can't get an NHS dentist. And I just want to explain my credentials. Like I was an NHS dentist there between 2005 going up to around 2012. And then I was a mixed dentist there between 2012 and 2014, 2015. And I've been doing only oral surgery and implant dentistry since 2015. So for the last decade or so. So I'm kind of well poised to kind of tell you, based on the old system that nobody will know there now, what it was like, and based on the system there that kind of came in 2006, and then the so-called changes that have been done there to it as well, and the real reasons why you can't get a NHS dentist wherever you are right now. The interesting thing is that a lot of people will come, and you never have these like longer format videos. What happens is that somebody will come and it'll be on something like GMTV or something like that. They'll have like a few minutes to explain it. There's absolutely no way you can explain the subject within a couple of minutes. So I'm going to try my best to explain it in as short amount of time as possible to not bore you guys. So let's talk about when I kind of first started dentistry. It was basically a fee per item based system, right? And that fee per item system was just kind of coming out of it. Basically, fee per item is where somebody would have some decay in their mouth, or they'd have a tooth that would need treating or whatever, and they would come in and they pay for that, and it'll be a reduced fee that they'll be paying there for that. Government would top this up, and it would be cumulative. So they might need, one filling, 3 fillings, 5 fillings, whatever. All of that would kind of add up, extractions, they might need dentures. All of those would add up to the total. And there'll be a maximum total that you get to, which is about £500, something like that. And if it got to that stage, most of the time it would end up going to something called prior approval. So you'd have these dentists who basically worked for the government. They'll kind of go around and they'd basically check and see whether you would be doing things correctly. Like, are you prescribing too many fillings to this patient? Are you prescribing too much treatment? Are they getting the appropriate treatment? Whatever. And then once they're happy with looking through your notes and your x-rays and all that you're doing the right thing, then you'd be approved to be able to do this treatment plan on this patient and charge that to the patient, right? So when the Labour government came in 97, they kind of thought that, this is a bit of an unfair system. And their aim was to change this to make it so-called fairer to people who were on lower incomes but were not in receipt of full benefits. So basically what happens on the NHS in dentistry is that if you are in receipt of certain type of benefits, you get all your treatment free, okay? If you aren't in receipt of certain types of benefits there, you still have to pay for your treatment, but it's a reduced amount, okay? So a lot of NHS dentistry is basically funded by this group of people who don't fit into those benefit categories or don't get full benefits and basically end up paying for that. So you get some people who might be very low income but not on benefits, who would end up paying £400 or £500 for their treatment. Obviously they couldn't afford it. So what they did was they brought in this system called the UDA. So the UDA is a system there where each practice would get paid a contract based on the amount of treatment that they would be given. There will be a total amount that practice would be given. And from that, they would have to do all of their treatments within that pot of money. So there were 3 different bands. There still are. And those 3 bands there are band 1, band 2, band 3. Band 1 is in essence examination of the patient. Band 2 is basically where you're doing certain treatments, extractions, fillings, root canal. That's changed there a bit now. And then the final one there, which is basically prosthetics. And prosthetics is things like dentures, crowns, stuff like that. And that would fit within the final category. And basically what would happen is a patient, whether they needed 1 filling or 10 fillings, would still pay band 2 costs. And if they needed 1 filling, 1 crown, 3 crowns, 5 crowns, 2 dentures, etc., they would still basically pay a flat fee for band 3. So what it then meant was that some people who had high levels of decay would end up paying a flat fee, and they wouldn't be out of pocket. So in kind of essence, that's a good idea, okay? Because you might have some people who really can't afford treatment who then get treated. However, one thing that nobody ever tells you is that there are no NHS dentists in the UK. There are some, actually no, I lie. There are some NHS dentists that work within community dental and things like that. Pretty much every dentist that you'll see is a private dentist that has an NHS contract if they do NHS work, right? And the issue with that is that that dentist is liable for the business, okay? And if you've got somebody who's liable for the business, what does every business want to do? It wants to basically make sure that their costs are as low as possible. So now you've got a system that has been created where if you have somebody who has very high need, for example, and needs lots of treatment, needs to be seen multiple times, is going to require large amounts of materials to be treated, then that person is basically going to cause that business to have a loss at the particular time, right? If you have somebody who comes in and they might need just a clean, or they might need a small filling, or they might need a patch up or something like that, that patient is going to make the practice a loss of money because they only come in and need small amounts of work. So overall, what used to happen was that the dentist would be like, well, you're going to have some patients who come in who need loads of work. You're going to have other patients who come in who don't need anything, and it kind of evens out. But actually what happens after a while is you have some practices, like the practices that I was in, where we stabilized all the patients, right? And we had this stable base of patients, very kind of loyal to us. We stabilized all of them. We got them to see the hygienist regularly, and they were really careful about cleaning their teeth, their diets, all that kind of stuff. And because of that, we didn't have to do a great deal of treatments, right? You'd basically, the patient will come in, they might have a crown that has failed after like 15 years. So you're doing 1 crown. Or you have a patient who comes in, oh, I got a little chip on my tooth, I fell over. Okay, fine, fix it. Seeing the hygienist, doing examinations, doing x-rays, that's it. Very little actual treatment is required, okay? So we're doing that all the time, and the business is then thriving, okay? But the at the time they were called primary care trusts. The primary care trusts, who are basically in charge of all of that, they don't like that, because they're like, wait a second, why are you not doing too many treatments? This other practice that is 3 roads down, they're doing loads of treatment. You're doing hardly any. Why? Well, because we're keeping our patients like healthy and stuff. Okay, well, you need to be taking on more patients because you know, you need to be averaging out the same amount of treatments that this other practice is doing down the road. But the problem is that if you imagine, right, say imagine you're a you know, you basically got a patient who's coming in, and you might have your established base of patients there who are all stable, okay, who you generally know what kind of work and all that kind of stuff that they need. And then you compare that to somebody who might come in, who you have no idea how they've been treated, what their you know, whether they've even had a dentist, what their general condition is like. Do they need multiple treatments? Are they going to need months of treatment? Are they going to be able to keep that stable? You literally have no idea, and you're taking on those patients, right? So that patient comes in, you've got no idea whether suddenly now your budget that you've made based on the fact of years and years of patients being stable is now completely gone, right? So all of this now means that if you are a dentist within an established area that you've had patients for a long time, there's zero incentive for you to take on new patients, right? Because if you do take on a new patient, you have no idea the amount of work that patient may require, okay? They may require so much work, right, that basically you're making a huge loss as soon as you see them. Okay. And like I said, there's zero incentives to take those patients on. Recently, what they've done is that they've increased the UDA rate, like we talked about there before, which is basically the unit of dental activity rate that the dentists get paid. But still, if that patient comes in and they need like 5-6 fillings and they're there for, you know, for 3.5 hours of treatment, you're in trouble straight away, right? So like I said, zero incentive to take on new patients. Okay, so that's the number one. That's why you have these practices that are like, we're not taking anybody on because they're stable. They've got their patient base. Not only that, you end up getting areas there where patient bases may not be stable, and also where you might have transient populations of people who are coming in and out of that area. And when you go and you establish your practice in that area, you have no idea. Okay, and this is fundamental when you're doing a business, right? You basically got to see what the market is in that area before you're starting your business. It's literally fundamental, right? So you have no idea when you come into an area what your patient base is going to be like. Now, you can come into an area and it's like there's a bit of need, but once we sort this out, these patients are really motivated, we can keep them nice and stable. And that's what we want to do. We want to keep people healthy, right? Or you could go into an area and people only come in for emergencies, or they only come in for one treatment, don't finish it off, don't, etc. Or might come in for, say for example, let me give you another example. Patient comes in and they need 3 fillings and they need 1 crown. Okay, so that pushes them into band 3. And band 3, the dentist gets paid more for band 3 than they do for band 2 because they're doing more advanced treatment. Patient comes in, gets all the fillings done, right? Gets the fillings done, doesn't come back again. Okay, so now you spent 3 visits treating this patient. You're now not going to go and get band 3. You've got to give them a certain amount of time before you can close that treatment plan. You're basically waiting at that point, like, what do I do with this patient, whatever. It's not stable. And this is why it always cracks me up whenever I see these idiotic, moronic political commentators, these journalists who basically come on and say, because of immigration, we got no NHS dentists. Now, listen, immigration is a problem. But like I just explained to you, if you've got an immigrant population with a high need, why on earth is a dentist going to want to set up their practice, their NHS practice there? Okay, you have no idea the cases that are going to come in. Okay, now we know that immigrants from other countries there actually have a higher rate of decay in general, right? They might live in poorer areas there as well. If what you said is true, that because of immigration you can't get a dentist, then there would be thousands of dentists in immigrant areas, right? Whereas literally just like thousands of practices, but because there's so many immigrants there, you can't get onto that list. Actually, the opposite is true. The opposite is that all the dentists are located in areas there where they've either been there for a very long time or they've got an established list, right? Now, if I was to go and set up a new practice, and I went and set up a new NHS practice in the heart of Chelsea, for example, right? It'll be a very calculated bet, because you can kind of say, okay, fine, these people are probably generally stable, right, in terms of their dental health, and I can help them keep that health there. The difference is when it comes to going to a place where you have no idea what is involved with the treatment on those patients. And the issue always is that we want to go and we really want to help people. We really want to basically make them so they're as healthy as possible. But the system is designed that if you take on people there who have the most need, you get punished the most. And it's a perverse system, right? It was designed basically to make it so it's easier for the people who don't have money to gain access to it. But actually what it does is it basically incentivizes the provider, the dentist, to actually not even go to those places. it's a weird system, right? Now I'm going to do another video at one point of how to solve this, because it's relatively straightforward to kind of solve this problem. Okay. What they've been doing for years and years is patch up. Okay. And like I said, I worked in NHS practice as a regular dentist. I worked as an NHS practice as a locum. And it was funny because I used to get paid a certain amount for a locum, which is way more than I used to get paid as a regular dentist in the practice, which is another weird thing where basically it's like, this is the reason why we don't have any money, because you can't get a stable dentist working in these places. But at the same time, it's like, oh, well, we've got to get somebody in, so we'll pay them more money. So why don't you pay the first person, the regular person, more money in the first place? But anyway, I don't want this all to seem like this is all about money, okay? Because there are going to be people in the comments saying, I never seen a poor dentist, whatever, okay? I'm going to explain in the second video what's going on there with that in terms of the business side and how we solve that and things like that. All I'm just trying to explain to you is why, if you go and move to an area, you can't get an NHS dentist. Because there's no incentive for them to take you on. Right, there's literally no incentive there for them to take them on. And in fact, you know, if you were looking for a dentist there because you had problems or whatever, that's even more of an issue, because basically, and the practice, they shouldn't really do this, but they kind of look at things and they're like, oh, wait a second, this patient says they need XYZ done, and they need a dentist. Straight away you're thinking, okay, it's not just that, there's going to be multiple other things that they need there as well, which is why pretty much I went into private dentistry, because I can implants and certain types of oral surgery that I do are not even available on the NHS, right? And because of that, it was always a compromised system. But after all this waffling for like 17 minutes, right, the real reason why you can't find NHS dentists got nothing to do with dentists not getting paid, dentists not wanting to do it, whatever. It's mainly because of the fact that you have no idea what's coming through your door at that point, right? And for any business to run like that is impossible, absolutely impossible, right? And for some reason, the new Labour government, even though they said they're going to get rid of this, have decided to carry on, but change the bans there very slightly to a very even more idiotic system. The other thing is, this system basically has been propped up for a while, right? And the reason why it's been propped up for a while is basically because the reason why it's been propped up for a while is because we had loads of dentists there who were coming from Eastern Europe to come and plug the gaps where people didn't want to go and work. And now that's dried up there as well, because they would accept a lower UDA rate. Now they don't want to accept that lower UDA rate. They want to accept a much higher UDA rate. They also want to earn a certain amount of money. They want to have a certain amount of conditions, etc. And a lot of people have gone back to their own country. So now it's even more stark than it was there before. But to blame one group of people there for it is absolutely ridiculous. So I hope, guys, that makes sense. And I hope it doesn't come across that I'm like saying, oh, it's because they don't get paid. It's not that. It's more about, you don't know what's coming through the door, man. And you can't run a business like that. Anyway, guys, I'm sure the comments are going to be very interesting. I'll see you again next time for the next video where I explain how to fix it.